Good morning, everyone, and welcome to the Informatics Institute Friday PowerTalk Informatics Seminar Series. I'm very happy to introduce today's speaker, Dr. Joanna Abraham. She's Associate Professor in the Department of Anesthesiology and also the Institute for Informatics at Washington University in St. Louis. She earned her Ph.D. at Pennsylvania State University in Information Sciences and Technology, and she has an interdisciplinary background in computer science, human factors, and biomedical informatics, which is very much about where we are in informatics. She's a researcher and national expert in developing, implementing, and advising on informatics tools to promote collaboration and patient safety, including for medication ordering, clinical communication, coordination, transitions, telemedicine, and machine learning to assess risk, and shared and distributed cognition for critical care teamwork. She has her tools have been implemented in multiple hospitals, and she's had over 60 peer-reviewed publications in leading journals in informatics and patient safety. She has multiple been awarded and serves on national panels on patient safety, and also been elected as a fellow of the American Medical Informatics Association, so FAMIA, and also most recently she's a FACMI, so a fellow of the American College of Medical Informatics. And her talk has to do with these topics: augmenting, postoperative, handoffs.
Thank you, Amy. I do appreciate the opportunity to present this research at the Informatics Institute, and I'm really happy to present some of the recent research work that I've been doing related to postoperative handoffs. To begin, I'll just start off. Let me see if my slide advances. Just to give you some background on patient transfers and what postoperative handoffs mean. So there are over 300 million surgeries that happen worldwide, and of which approximately 55 million is just conducted in the US. And usually, typically, patients are transferred from the OR for postoperative recovery to the ICU, depending on the type of surgery. And I'm mostly interested in OR to ICU transfers. So in addition to the setup and the equipment that's been transferred, we also have a transfer of information, control, and responsibility from the OR team to the ICU team. And that's what is referred to as handoffs. Handoffs are usually used as a forum for maintaining care continuity. And the main function is information processing, which is basically focused on transferring information, accurate and complete information across from the OR team to the ICU team. In addition to information processing, there are other related functions that have been highlighted in research, such as shared cognition. Many of you have heard the words team mental model or shared mental model that needs to be built. Just to show you again, it's a team-based approach. So this is really critical for maintaining care continuity across the teams. The other functions related to handoffs are resilience, which means can you identify errors and detect errors in time during these handoff processes and recover from them? And the idea is that when you have a new team taking over, they probably can bring in this fresh eye perspective to handoffs and identify those errors or mistakes that happen during these processes. The last one that's been highlighted in research by several people are the notion of stereotypical narratives. So usually when you do handoffs, you try to talk about the narrative in such a way, okay, this is a typical AKI patient with so-and-so conditions, and this is the surgery that was performed. What researchers have published related to stereotypical narratives is trying to highlight the deviations from the narrative so that you can look at those outlier cases or risks so that you can talk more about those during these handoff events. So to ensure safety in handoffs, and handoffs has actually become a big safety threat, and to ensure safety during handoffs, the Joint Commission came up with this goal that all hospitals need to implement or adhere to some kind of standardized approach to communication, and also include an opportunity to ask and respond to questions. And to adhere to this goal, you'll see that several institutions and hospitals in the United States started focusing on using protocols. Protocols are basically like a process-based guide as to what needs to happen. As I mentioned earlier, it's really moving patients from the OR to another location. So there's a lot of coordination that has to happen. For instance, the thing that's marked here in red is 30 or 45 minutes before the patient arrives in the ICU, there needs to be a phone call that's made, making sure that people in the ICU are prepared for the patient from the OR, and so forth. So you'll see that there are different steps that need to be done before the patient gets there. And the second graphic I have here is related to a checklist. It's basically what kinds of information elements need to be transferred during these handoffs, and you can see like I mentioned earlier, it's a team-based approach, and you'll see there's a handoff leader that starts that gives a timeout for all the participants during handoffs. Then the surgeon provides information on what the surgery situation was and what was done. And then you have the anesthesiologist who talks about the anesthesiology course and the current state of the patient and what needs to be done. And finally, you come back to the handoff leader, who then gives you this opportunity to ask and respond to questions. So it's pretty straightforward in terms of how the checklist is designed based on the information elements that need to be transferred in such a way that you can still maintain care continuity. So most hospitals started approaching this using protocols and checklists, and you have certain institutions that actually did both, where you can have a bundled approach. Irrespective of all these standardization efforts, in 2017, a report came out through the Sentinel event alerts, which still talks about handoff being inadequate, or there are several failures in handoffs, and which leads to medical errors and Sentinel events. Actually, there are 70% of medical errors are caused due to poor communication, and half of those communication errors are actually related to inadequate handoff communication. As a result of which, there was increased emphasis on perioperative handoff safety, especially from the Anesthesia Patient Safety Foundation, because I'm interested in perioperative handoffs. That's the organization that gives us guidelines in what needs to be done for improvements. So the first thing that they did was they came up with this conference where they got people together to come up with a statement in terms of how to achieve consensus on getting it right. So we all realize that, recognize that there are handoff failures in different parts from in the perioperative spectrum. It could be OR, within the OR, it could be OR to ICU, OR to PACU, and so forth. So there was a lot of emphasis around that. At the same time, the Anesthesia Patient Safety Foundation, as a result of which made a collaborative across the United States, referred to as National Multi-Center Handoff Collaborative, or MHC. And the primary goal or mission for this particular collaborative is to getting handoffs to become more safer. And I do lead the EMR implementation work group for this collaborative. And finally, at the same time, there was a lot of reports in our own institution regards to Sentinel events, and it was rising. And our hospital and institution came up with this task force, which I was part of, where we were trying to figure out ways to, one, actually collect data on handoff errors or communication failures, and two, come up with some methods to actually address it and implement and then track these in the long term. So I'm going to use this user-centered design approach to talk about the different steps that we worked on as part of this project. And I'm sure, given this is an informatics group, all of you here probably have heard the word user-centered design or human-centered design. It's very simple in its methodology. It's really getting your users or your stakeholders as part of your intervention design and the entire inquiry process. As you can see by the arrows, it's a very iterative process where you can jump from one step and come back depending on the improvements you have made or not made. So there are 4 steps. The first step is contextual inquiry, which basically means, can you identify what's going on in the context right now, identify what the barriers are, what the enablers are, and also understand what the workflow is. The second step is then looking into design. If you do identify barriers and you do identify gaps in the handoff process, the next step is to then design some kind of intervention to address those barriers. And we refer to this phase or step as design ideation. So coming up with ideas around what are those features or what are things that need to be done, either in the process or in the tool itself. The third step is then coming up with prototypes. It could be low fidelity prototypes, as simple as paper-based paper copies of how you want this tool or checklist to look like, what are the steps in the processes that need to be improved. And then you refine it and then make it into a more high fidelity EHR-based or electronic-based intervention. And the last step is then you develop the intervention, implement it, and evaluate it using a trial-based or a design that's robust in getting what you want in terms of outcomes. So for the rest of this talk, I'm going to briefly summarize what we have done with regards to these different steps and where we are right now. As I mentioned, the first step for us was to understand what has been done in our institution. So we call it handoff bundle concept generation, trying to identify where the barriers are. So as I mentioned earlier, our institution, similar to other places, did implement a standardized process. So the first study for me was to understand like what the failures are with the standardized process, like what is not working, what the barriers are. So as part of this, we did map out the process, and this is what our protocol is in terms of what is applied or implemented here. You can see a pre-handoff preparation or pre-transfer phase. There's a team-based bedside handoff phase, and these are the instructions or the steps that need to be done. Similar to what I showed you earlier, it's very protocolized. Everybody in the institution has a copy of this, and they know who goes first. There's a turn-taking behavior here. You have the circulating reporting nurse as the handoff leader who provides information. Then you have the surgeon or the surgeon's team providing the report. And finally, you have the anesthesiology team who provides their report. And in the receiving side at our institution, which is very unique to our setting, in addition to the ICU team, typically you have the OR team and the ICU team, but at our setting, we do have an EICU team as well. Probably you all are familiar with EICU, so it's basically a telemedicine ICU setup that we have at WashU, and all their particular role in handoffs is trying to participate in this handoff process as part of the receiving team. So they're a remotely placed clinician who actually participates with audio and video feed for these handoffs. We also have a checklist in place, and this is the information transfer or communication checklist. And this gives you a list of information pieces that need to be transferred by the anesthesiology team and the surgery team. So some examples are the anesthesia team provides information on the surgery performed, the type of anesthesia provided, allergies, and so forth. And you have the surgery team that talks about the actual surgery, and then the surgical findings, blood work, blood loss, and other things. So this is the process that we had at our setting. And our first step in this observational contextual inquiry phase was to understand what is going on. And as a result of our several months of observations, interviews, and focus groups, we did identify several barriers to handoff safety, irrespective of the handoff standardization tool that was implemented at our setting. So as I mentioned earlier, this is the process. You have the OR team to the ICU team. There's a pre-handoff preparation phase in the protocol I mentioned, and some of the things that we noticed early on was the timing was not right in terms of when the preparation happened. The notifications were sometimes missed. People would not notify the ICU team that a transfer is happening, and there was no preparation for the report itself. Some of the team members, such as the anesthesiology team or surgical team, have no time to actually take time out of their surgery to prepare for this report. Transfer and setup phase is after they've transferred. We did identify that there were issues with regards to delaying the reports. There's a lot, you can imagine if you go to the ICU, setting, you'll see that there are lots of things that happen in the ICU. And when you have two teams, the OR team, the patient on their bed, as well as the ICU team, there's a lot of distractions, noise. It is hard to team because you just can't get everybody in the same room at the bedside to do these handoffs, and it's just cramped because it's one room where you have all these people standing around the bed. In terms of the handoff delivery itself, the handoffs happen at bedside in the ICU. We did notice that there was definitely poor handoff attendance. Not everybody in the protocol actually attended these handoffs. Even if people did attend, there was selective attention or distractions because they would have side conversations during handoffs where the process actually was not being done. There was a lot of omissions. We did track the information that was transferred using the checklist. And the other thing that we noticed was the checklist and the protocol that we showed earlier was not EHR accessible. So people really never knew, unless they memorized all the information about the patient and the checklist. It was hard for them to identify or communicate the critical pieces of information to the receiving team. And the last phase that we identified was the post-handoff phase. This is the phase after the handoff communication happened, where they give you some information on any questions and have some post-transfer discussion. As it is important with any communication event, there's limited guidance on what the contingency plans are if things didn't work out well for the patient. Missing contact information, it is required that the surgical team is accessible at all times, but there was always information around their contact and how to get to talk to the surgical team missing as part of the handoffs. And finally, you all know there's a lot of fatigue and burnout in general at our institution. We also did a compliance study just to see whether everybody is actually complying or adhering to the standardized handoff bundle, because as per the Joint Commission, if you have a standardized process and a checklist, the goal is that these will lead to better handoff quality and safety. So we had our EICU teams with the knowledge, with everybody having the knowledge that these are going to be audited. We had our EICU team audit around 300 cases, and we found that, I just want to focus on the handoff quality itself. You'll see that it is average to below average. Most handoffs were actually were rated or rated around 3 on average and 4 at the most. We had only 9 handoffs that had a rating of 1 and 90 around 2. So there was definitely some variability in how handoffs were done across these units. So moving on, given that we had all this information on where we can make improvements based on the barriers that we identified, we wanted to start to come up with some design ideas around how to improve the process. So we did 2 things here. One is to do a literature review on what's out there, because obviously as researchers, we really don't want to reinvent the wheel. We wanted to see what's out there and what standardized tools have been used and applied, and what are the ones that we can learn from so that we can apply some of the features that other institutions are using at our setting. And the second piece to this was then conducting a study in our own institution to see what works for our clinicians. So the first thing, like I mentioned, was a systematic review and a meta-analysis to look at other handoff tools that are out there. And some of the things we did was obviously a systematic review. During a systematic review, we did identify several studies around, or several interventions around OR to ICU handoffs particularly. There were 32 tools, and this is a breakdown of the different types of interventions that were out there. So you'll see 3 information transfer checklist, 1 protocol, which is basically the process-based steps, and 28 bundles. And this is where it's interesting for us because our institution already had these bundles. So there is some evidence that these bundles are prevalent across other institutions. And you'll see there are only 2 that were EHR integrated and 2 that were mixed paper and EHR integrated. So this, I'm sorry for the busy graphic here, but this gives you an idea of the different interventions that are out there. If you just look at the white spaces and the white boxes, you'll see that there's definitely fewer variability across institutions. There are definitely things related to the transfer phase or the pre-transfer phase that is missing across institutions. And the orange shows you the OR to ICU handoff communication. And that's pretty standard across institutions. So there was some signal for us that institutions have a process in place and they are following some kind of checklist and some kind of process in terms of these handoffs. Similarly, we looked at the information transfer checklist and tried to look for overlaps, and there were 11 content categories that were across different across these different tools, 32 tools, and these are the 11 content categories, and across them we tried to look for overlaps. And here also you'll see that there is definitely some consistency across institutions in what they actually communicate during these handoffs. So using all of this information, we were able to look for those elements that are actually critical for our redesign process, as well as our redesign of our checklist. We also looked at the handoff functions, as I alluded earlier. Besides information transfer, which is a key function for handoffs, there are other things that are important because it's a team-based approach and a team-based process, such as shared cognition, stereotypical narratives, and resilience. And we wanted to see if these interventions had explicit functions or some kind of implicit functions that actually supported these different functions. And you'll see that there were only 5 tools that of the 32 that actually had some functionality or feature within their intervention that supported these functions. We looked at the impact of the standardization on outcomes based on these different studies, and these are just the significant results in terms of improvements. Technical errors referred to as process-based errors, and you'll see that there was some improvement across these interventions. There were fewer information omissions, better information sharing score, and time to analgesia dosing is another important variable that people used. And we did find that was also pretty significant in terms of its impact. But we also noticed that there were no changes in other handoff-related outcomes, such as handoff duration, because you can have the best perfect checklist, but if your duration of handoffs is extended or if there's no improvement, it's hard to tell whether your checklist is useful, because as OR to ICU transfers happen, these are really time-sensitive events because our OR clinicians need to go back to the OR for other surgeries. So it's not that they can spend the entire amount of time in the ICU. So handoff duration is a critical outcome for us. Realized errors are errors that are realized after the handoff by the ICU team. And we did see that there was no change or there were partial improvements in those outcomes. And other things that anesthesiologists are interested in are antibiotic administration delays and ventilator time. The other thing that we were really looking for, because as I mentioned earlier in our study, we do have a bundle, we did find people having issues with the bundle and they were not using the checklist. So we wanted to look at whether these different studies actually evaluated sustainability or improvements after the study and how time affected the use of these interventions. And we did see that there was limited sustainability across institution when it came to these tool use, and the outcomes, some of the outcomes actually deteriorated over time. Although initially there was this perception of improved handoff quality, it actually deteriorated after 6 months of the study. So the next piece that we wanted to, having learned from our systematic review in terms of what those features should look like, we went back to the drawing board and talked to our clinicians at our setting and multiple stakeholders to come up with design requirements for a care transition intervention at our setting. And in this particular study, we did find certain specific requirements with regards to process-based improvements. they really wanted to establish an active role for EICU clinicians. I mentioned earlier in the process that the EICU clinicians participate in these handoffs, but what we noticed during our process maps and during our contextual inquiry is that our EICU clinicians do not have a role. So based on the process-based protocol, you have the anesthesiology team, the circulating nurse, and the surgical team have roles. Similarly, you have the ICU team have a role, but the EICU clinicians, although they were participating, they did not have an actual role in the handoff. So that was a suggestion that was provided by our clinicians because they could actually help with identifying those errors or supporting resilience, as I mentioned earlier, come up with a fresh eye perspective into the handoff process. The other interesting idea that was put out to us was coming up with a new role for EOR clinicians during handoffs. So EOR, similar to the concept of EICU, it's a remote team that actually monitors the OR patients in the OR. So these are team members we do have an EOR again, it's a unique feature at our setting where we have an EOR. They remotely monitor and do like a surveillance of patients while they're having their surgeries, and they provide some kind of guidance for bedside clinicians, especially when they are fatigued and burnt out, or if they need another perspective on certain difficult cases. So something that was mentioned in our data collection and that repeatedly came out was probably to use the EOR team as part of the handoffs, because they can probably pull notes in time and give you things that are needed that we are stuck with, given that the bedside team it's difficult for them getting this information in real time. So in terms of information checklist requirements, we did a process referred to as cart sorting. It's a user-centered approach where you come up with a list of elements and you get clinicians to work together and sort elements based on what are the must-haves, which we refer to as core elements. Flexible elements are maybes, and unnecessary is like things that they don't need. This is really important if you want to have a list of information in terms of coming up with a tool that it does not have all the information, but the actual must-haves for every patient. And our clinicians came, and when I say clinicians, it included surgical team members, it included ICU team members, it included anesthesiologists as well. So they came up with these lists, and we categorized it based on those core, flexible, and unnecessary elements. So using this information, some of the things that came out during our focus group interviews were that they want to really look at patient risks and try to, instead of having a standardized list for everyone, trying to come up with something that's more patient-centered and tailored to patients' issues. So as a quote here, some patient issues just don't fit the standardized structure. So it was really important for us to come up with some adaptive mechanism so that we can show the most important information based on patient's risks or surgical situation. And you have other team members here do talk about it's just harder to find the details when you look for these information, and they really feel that a standardized checklist or a process is definitely cluttering up the report because you're focusing on the wrong things during these reports, or at the other end, you're just not focusing on anything because there's a lot of information that's being transferred. So some of the ideas that came out was we really need something that is more flexible and that's more patient-centered over a complete standardized structure. Other things that also came up was patient risks were a key piece, as I mentioned earlier, but they also wanted to look at risk factors, things that contribute to these risks. So we do have clinicians talking about, I do care about why a patient is at a risk for something. If they have a risk for mortality, in this case, they want to see, okay, is it an elevated risk, or is it normal for this patient to have this risk based on the comorbidities for this patient? So there were definitely things that came up in terms of risk factors. Other things that our ICU nurses were interested, especially because they provide the management and care management process after the patients are being transferred, is how can we prevent those risks? Once you know what those complications are, you can probably do things in the ICU that can prevent them and can actually lead to better risk management strategies. The other things that were pointed out during our focus groups were we really don't want to see all risks, because some of those risks may not be things that are actionable. Like, let's say you can change patients' age, or you cannot change patients' smoking status, but there are things that you can do in the ICU that can be helpful and can mitigate some of those risks. So people were really keen on only showing or having modifiable patient risks so that suggestions can be provided for mitigating those. So as examples here, like what might change something I do? So can I do something in the ICU that can change the trajectory for the patient? So having all of this, we did go back to our process, because we did have initial ideas on what this design should look like. We had a good sense of the information checklist, and also had a good sense of what the process should look like. But this whole idea around risks and risk factors were actually very new to us. So that's when we got into this whole space of machine learning and trying to figure out how we can use machine learning models and AI to actually make those predictions for our patients within the context of handoffs. So our first study was, okay, coming up with these risk predictions. And then the next piece that I will present is coming up with design ideas for presenting some of this machine learning output. So this is the first thing we did. We had, based on our contextual inquiry, we did a series of studies, and our studies, based on our studies, most our clinicians in the ICU and in the OR were really interested in 4 and 5 complications: acute kidney injury, delirium, DVT/PE, and pneumonia. So our first study related to this was trying to predict these complications. And as you can see in the graph here, we were able to have high performance for these different complications. And we were also interested, and we used preoperative and intraoperative data to make these predictions postoperatively. So I just want to show you this graph where we use intra-op and pre-op, and the green shows you the combined data set. As you can see, obviously combined, if you have both data sets, it's obviously better in terms of its performance. But what was interesting to us is just having the preoperative data, which is the orange bars here, actually did pretty well in terms of its predictions. So if we did not have access to our intraoperative data, we could still make good performance predictions for these complications with just the preoperative data. So I'll just walk you through an example as to why this is relevant for handoffs. So let's say you have, and how we plan to use it. So let's say you had a patient, 65-year-old with COPD, and is doing a surgery, pneumonectomy. With the term pneumonectomy, you probably understand that this patient is already at risk of pneumonia. An epidural is placed in the preoperatively, and then they do the surgery. They provide some fluids, and a right chest tube is placed, and finally the patient is extubated and the patient is transferred to the ICU with a high flow face mask. So having this particular case, let's say we are interested in looking at what those patient risks are for this patient. Based on our model predictions, we found the gradient boosted tree actually having good performance, and it predicted that the patient is at high risk for pneumonia. The interesting thing for us are the explanations, like why, as our clinicians wanted, like why is this particular patient at high risk for pneumonia? So we did identify certain key factors or risk factors based on our data, that the patient has a history of anemia, has an elevated white blood count, a low body mass index, and the tidal volume and respiratory rate signal. So we did have some indication based on this data that this patient has these risk factors. This is really important for us because it can then inform postoperative care plans. So let's say you were communicating this information during handoffs. Our nurses in the ICU and our team members in the ICU can probably make some plans in terms of actually mitigating some of these risks before it happens. So trying early mobilization, getting them up and walking, doing pulmonary hygiene, or scheduling or providing extra oxygen. So there are things that can be done to prevent these risks from happening in the ICU. So this was our idea around how these can be used during these handoff events. Having done that, our next step is then how do you present this information? As a computer scientist, it's great that I'm able to do these machine learning models and make some innovations within the technical aspects of it. But then we really want to see how can we integrate this within the clinician workflow and also make it in such a way that it is usable and useful for our clinical partners. So we did a study where we looked at presenting this information for our clinicians, and also getting some ideas on things that they wish to see in these handoff interventions. So this particular study used a scenario-based design, which basically means we use patient scenarios. These are real patients. We make these predictions. We come up with some design ideas and prototypes where our clinicians would comment on whether these prototypes makes sense to them, and they can pick which ones they like and dislike. So the first thing that we wanted to investigate was the format for these risks. Which format or which structure should we provide these risks? So we had three choices. One was this table, this graph, and the third one was a narrative, like in text form. And most of our clinicians really preferred the tables and graphs to display and present this information. And it's very intuitive for them just to see this in a graph. And we had some differences between nurses and our nurses, residents, and our attending anesthesiologists. And so we provide some choice for them to pick which one they like. The second piece that they were also interested in the format was, can they have some kind of pop-up, because our attending anesthesiologists do want to see additional information on how these risk predictions were made. As I mentioned earlier, you have the accuracy of prediction, and that was something that our anesthesiologists were interested in, so that they understand how these predictions were made, and it's not a black box where you say the risk for this patient to develop delirium is 49%. So that was another idea that was thrown at us. In terms of risk factors and its format, you can see here that people did like grouping those risk factors based on things that actually lead to risk versus protective factors, so that they can understand what are the things that are actually contributing to dementia or contributing to this particular risk. So we did provide them two formats, and this was the format that all our clinicians preferred. The other format was trying to group it under preoperative and intraoperative. So let's say surgeons wanted to see just the preoperative risk, they could look at pre-op, and if you want to look at what are the factors that contributed that were part of the intraoperative setting, they could actually refer to that. But most of our clinicians, actually, majority of them preferred increasing risk and decreasing risk as opposed to the phase of care. In terms of content or what they want to see, as I mentioned earlier, people are interested in seeing not just the risk percentages, but also the accuracy of the predictions that were made. So people were interested in how accurate was your predictions or models in terms of coming up with these predictions. So providing either confidence interval using an error bar, or providing it in the table format where you have some kind of accuracy measure. The thing that we are still struggling with is coming up with these thresholds. Obviously, people in informatics are familiar with alarm fatigue and alerts and too many alerts. So coming up with a threshold that is meaningful is still under debate. People do want to see those thresholds, but identifying what is clinically relevant is still unclear to us at this moment. So we are hoping that we will learn more as we do more studies in this area. The last piece that our clinicians were interested were providing some relative risk numbers or relative risk so that they can actually compare that particular patient to the rest of the population that performed that particular surgery. So that gives them some context in how things went for this particular patient, and also gives them a better idea on what needs to be done in terms of escalating some care or preventive measures. So the graph here shows you the yellow is the average patients with that particular complication, and the black is this one patient under investigation. So based on all these UCD, the user-centered design steps that I mentioned earlier, our biggest lesson was a one-size-fits-all does not work in this process. And we need to really move away from rigid standardized approaches to more flexible standardized approaches. So we came up with this term that, okay, we need more intelligent or smart handoffs, something that's more personalized as opposed to just providing a checklist of patient age, surgery, and so forth, but rather say Abraham surgical procedure, whatever is specific to my surgery. So two things that we learned from this work was that, one, we needed to re-engineer our process at our setting by incorporating our telemedicine team members, both EOR and EICU, and that can support identifying errors, bringing in a fresh eye perspective, support anticipatory or contingency planning, and finally, it just helps with the extra set of eyes or extra set of feedback that you get from a telemedicine group that are not at bedside. And the other piece is we need to come up with ideas around redesigning the handoff content. And one of the things that we learned in our study at our setting was using machine learning or AI augmented reports to support this information processing, shared cognition, and stereotypical narratives, where you can actually, instead of talking about instead of communicating every piece of information, you can spend more time talking about patient risks and what needs to be done to avoid those risks. So I have done a significant amount of work in this area. So it's something that I'm super passionate about and I believe in. So if any of you are interested in any of this, there are a few articles just talking about flexible standardization and how we can use technology and artificial intelligence to support handoff processes. So this is where we are right now in this particular project. We are working on developing this handoff bundle and implementing and evaluating it. It's still in its early stages. We are hoping that in 2.5 years we will have everything figured out, but we are still trying to figure out how this is going to be implemented, and then conduct a study which actually gives us results on improvements or no improvements. So that's where we are. And this gives you an idea of what we have pictured. So we have, as I mentioned earlier, we have the telemedicine augmented handoff process at the top. You have the telemedicine teams, you have the EOR clinicians and the EICU clinicians who would be part of this process. And then you have the usual process where you have the bedside team providing these handoffs. So there all these things that are colored in purple are the steps in the protocol. And the piece that is here is related to the machine learning augmented report, where we have a personalized risk score. And for people who are interested in understanding the risk factors, they can click on a button and then they get all the data related to the risk explanations itself and a report on how these were done. So to close, I just want to give you a sense of, because the talk here was mainly related to the tool and intervention itself, but we do have other areas of research or opportunities that we want to focus on. So we published a roadmap for perioperative handoffs 2.0, which is basically where should this field or research and practice go towards, or where should it, what the next steps should look like. So we have identified 5 clusters. The first cluster is really trying to figure out what this protocol should look like. And for those of you who understand the handoff space, there's a lot of debate around national standards, measuring outcomes, methodologies, because there's no gold standard for handoff in itself. So every handoff is different, especially with all these personalization. It's just difficult to say that whether we missed any information for across patients. So there's a lot of research in the methodology space that needs to be done. The cluster 2 is really focused on the teams, just understanding how to build a good team. How do you come up with psychological safety within a team where everybody can open up and speak up when there is an error? And how do you change the organizational culture? Because it is hard to implement tools without a team-based culture as part of the organization. Cluster 3 and cluster 4 are the ones where I'm focused on mostly, where we are looking at the process changes, workflow redesign. There's a lot of work that needs to be done with regards to patient-family engagement. There are very, very, very few articles talking about how to involve or integrate patients and families into these handoff processes. For OR to ICU handoffs, it's difficult because patients are usually intubated and they're not in a position to be part of it. But there are other perioperative handoffs where we feel families can be involved and patients can be involved as part of it. Tools and cognitive aids are things that I mentioned earlier. We are in this phase where we want to have more adaptive cognitive aids and augmented tools as opposed to a standardized paper-based or EHR checklist. And the last piece that we want to focus on is on education and training. So we are interested in coming up with curriculums where they emphasize the importance of these risks and just emphasizing those, learning more about the outliers as opposed to the typical narratives. So you can actually look at and use this as a learning forum for understanding what goes wrong and what those strategies should look like. And also trying to come up with a communication program, so it's more part of the curriculum as opposed to a separate thing that you learn or experience during your practice. So that's, and if you're interested in any of these, I would encourage folks to look at this conference report. This was a conference design studio that we conducted a year ago, which talks about how these different clusters were formed and also where the field should move forward. I think that was my last slide. I just want to acknowledge my research team. Definitely, I do have a great, a big village behind some of this work, and these are the different team members as part of this journey. And then in terms of funding, we do have funding from several institutions. ARC is the most recent R01 that is actually, that I mentioned as part of UCD Step 4, where we are working on an R01 which actually evaluates this process. And I did receive internal funding while I was starting this work. And NINR is the funding for the telemedicine piece. So with that, I will stop and see if any of you have any questions for me.
Oh, thank you for a wonderful presentation. Yeah, I guess we don't see handoffs as patients, and it's sort of, you just kind of assume that they happen. And I'm just thinking, like, dating myself when it was just all done on like an index card. It's pretty sad. Yeah, I'm just kind of yeah, but it's so important. Could you say something about like, how is it integrated with the EHR? Like when someone is doing a handoff, or maybe not this one, this particular one looks like you're still haven't quite gotten to that stage yet, but like, would it just be a screen on there, or it's just freestanding something outside the EHR? Where would someone, how would someone interact with it?
Yeah. So I think based on our review itself, like I said, there were only a couple that were integrated with an EHR. So for instance, Epic has its own handoff report, but some of the issues or challenges people have been facing is that they don't know that it actually exists within Epic, and because everybody has their own view, and based on what role you play, it's just difficult for you to access the report itself. So people have given up on actually trying to figure out how to get to it. And even the Epic report is just a standard report. It does not have, it's just what the problems are. And most of the information is redundant in the Epic handoff report. what the problems are, the surgery, and then there are some LDAs and some medications that are part of the report itself. The piece that people are struggling with are related to situation awareness and planning, because the EPIC report follows the IPASS structure, which is what illness, severity, problem list, awareness, and like situation awareness and planning, where you try to put in some notes around those risks and anticipatory management and the care plan for the patient. But there, again, given that not a lot of folks know how to use it or where to access it, it's not been used. And it has not been developed really for OR to ICU handoffs, because the teams are very different. So it does not have something for surgical team members. It does not have something specific for anesthesiology team and so forth. The challenges that I think are, at least based on our institution, I know the challenges that they are facing. They don't have access to EPIC or EHR or any computer system at bedside, because it's a small space. Like you just come, you go up to the ICU with your paper-based information based on what you've written up, and you provide that information. So EPIC is really not playing a pivotal role in the handoff process. The way we are trying to implement it, obviously we are using EPIC as our platform, but because we can do directly, especially with the machine learning piece, it's hard to integrate that without using or testing it within the cognitive compute platform, and we're still trying to figure that out. But we do have another vendor who's helping us with this whole process of integration or embedding it within our EPIC system. So our hope is to, and we have screens, we have shared displays, and our hope is that the eICU team can share the handoff tool on their display, so everybody can actually see it while they're presenting the information. So that's one strategy or a workaround that we are trying to use. It's not the best approach, though. I think I gave you more information than you asked. I see Hope had a question.
I do, thank you. How did you go about recruiting participants? Did you send out surveys to handoff team members at various institutions? What did you do?
Yeah, so we do. Yeah, that's an important thing, because without our participants, we can do the study. So we start off, all the studies I do start off with observations, so that we understand who the people are. And also they get an idea of who we are as researchers and our goals behind the research. So we always do like a month or month and a half of just observing our participants, observing the setting, understanding the process before we jump into more structured ways of collecting information. So we have done, we do interviews, we schedule interviews, we email folks based on our IRB rules, and we have flyers out for people who are interested in reaching out to us. And we just email them, and it's mainly word of mouth. They probably would have seen us observing them prior to our cold email, so they already have some sense of what's happening and what the study is about. So people have been, so far, I've had at least, again, what I presented here is just one snapshot of the study, but I've had across these studies at least maybe 80 participants or 80 clinicians who have participated in different phases, and without any incentives, with zero incentives. So it's been really really mind-blowing to see, and I'm really appreciating people's time, because we really want to help in terms of improving the process. And I think, again, I'm part of anesthesiology, which makes a big difference, because they see me as one of them, as opposed to if I was just in another department, it may be different. So it's been really easy to get clinicians participate and give their time to do these different processes. So we have done interviews and focus groups as well. So, but no surveys yet.
Okay, thank you so much.
Sorry. Yeah, I was kind of following up on Hope's question that recruiting participants, that I was wondering how even acceptance of, kind of like you're telling someone how to do their clinical workflow, and I could see some people being resistant to that, unless they already feel like the system is so flawed that they're happy to have, you have is be helpful in a systematic way. So I'm kind of wondering, how that goes.
Yeah, so that part I don't know yet because we haven't tested our intervention or implemented anything yet. So we are still trying to learn the different pieces and finding out ways to revise their workflow. So we are yet to learn more about, okay, once we get people to do it, how people are going to react. So I don't know yet, but at least in theory, I know we would have a lot of educational and awareness presentation so that people understand the importance of the errors that are happening right now. And like I said, I'm part of this perioperative handoff task force. So it really helps in presenting this at a regular interval. So we do presentations, we make changes. If we do make changes, we come back to them saying that, okay, these were the changes that were made, and get more feedback. So they're actually part of the process. And that's why this whole user-centered design is not in name only. It's really important to involve them. And we use other implementation science methodologies. So there's one methodology that we rely on, or we plan to rely on, is implementation planning approach, where you have an advisory board that you bring together who are stakeholders. It could be nursing managers or people at bedside who are the ones who are actually implementing it. And you get them involved and they decide the process. So what I've presented in terms of my last slide, where, okay, this is what I want to do, or this is based on what I've learned over the years. But really, in reality, it is going back to them with that proposed model and see what actually can happen, what can be done. From a technical standpoint, we know this process will work. But again, in reality, is it adding more steps to their process? Are they worried about having this big brother watching over them and providing additional information? So those are things that we are still trying to figure out, and we do rely on this approach to bring them together, participate in these stakeholder advisory board meetings every 2 to 3 weeks, so that they give us ideas on how to do it, as opposed to us providing them information on how it should be done. So there's a lot of learning that we do along the way in terms of implementing it. But yeah, we haven't done that yet. So I will report back once I have that information.
Yeah, I had asked about EHR integration. So when you roll this out, or even for evaluation, how do you think that people will get to it? Will it be like a paper freestanding thing, or plug in?
Yeah, so it is going to be part of the Epic. It is going to be part of the EHR. It is just that it won't be directly on the Epics. So I work with analysts with the Epic team as well. So it's not, because I don't have any evidence that it will work yet, because we are yet to do the evaluation. So till I get that, I'm not implementing it directly into the Epic platform, but we are using this middle person or middle vendor I mentioned earlier, who has a single sign-on as part of Epic, so they can still access this software or this handoff report as while they're within Epic. Because the issue is, when you have other standalone tools, the issue is that clinicians would have to have an additional sign-on, or it's hard to go to a separate software or a separate website to figure out what the information is. So the idea is that we can have something within Epic so they can actually see it. It's very seamless for them. They will see the report, but it's not really part of an Epic installation per se.
Okay, yeah, thanks. All right, well, I think we're at our time. We're past time. Sorry. Thanks for sticking around till the end.
Oh, wow. We have only 3 people here now.
Yeah. Any final comments or questions from everybody before we say goodbye?
Would you use your stakeholder advisory board to do more of a heuristic evaluation of the process?
Yes.
Okay.
Yes.
Okay.
Yes. That's so we do have heuristic evaluation. So for the heuristic, okay, let me take that back. For the heuristic evaluation, because it's really meant to be done by experts, we do have expert evaluators doing that piece, expert clinician evaluators doing that piece. But then the stakeholder advisory board, because these are practicing clinicians and stakeholders from the bedside, we get them to do other usability testing, and we have a taxonomy that we follow where they can identify the issues and flaws around the usability of the our machine learning report itself. And so they do like cognitive walkthrough. So it would not be a typical heuristic evaluation in its actual sense.
Okay. Well, thank you so much for your time today. It's a very interesting study. I appreciate your time.
Of course, thank you. Thank you for staying.
Yeah, thanks everyone. Have a great weekend. And
Yeah,
we'll
thank
see
you.
at the next seminar. All
Yeah,
right.
thank you,
Bye.
Amy.
Bye-bye.
Nice seeing you. Bye-bye.